Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hi, everybody. Welcome to Melanoma Matters. Maybe I should just do it properly. I'm Sapna Patel.
I'm James Larkin. Hi.
Hi. So this episode is, let me see what episode number it is. It's going to be episode 46, I believe. And it's Fianlimab Cemiplimab. But we had a little recording issue. So midway through, we ended up recording the bits on different days. I think to the listener, it'll be fairly seamless, different microphones and all, because technically you and I are both on different microphones. So maybe it won't be as seamless as I think. But for the listener, it should be pretty seamless. But for anybody watching, you're going to see a hiccup in everything, just the background, the wardrobe, all of it, the lighting, all of it. But anyway, this is all to say we just had a little recording snafu. So the first half on one day and the second half on another. But I think we get to the meat of the issue. So that's it. Just a little pre-episode warning, whatever the opposite of a fact check is. Yeah. Nothing, right? You got nothing? I got nothing for that.
No, I don't know what the opposite of a fact check is. Yeah. No, I'll think about it.
A declaration? I don't know. Okay. All right. Enjoy the episode, everybody. Do you want to go on this one or do you want me to?
Yeah, no, I can. Because I'm gonna inquisit you. That's not a verb, is it? Actually, yeah, I'll come to that in a minute. Anyway, pause.
You said myocarditis on one. You said, and I assume that's the plural.
That is the correct plural. It's definitely correct.
Okay.
Yeah, I'm certain.
I put it in the show notes. I said, and is myocarditis a word?
Oh, wait, I've got one. Right, anyway, right, okay. Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
And I'm Sapna Patel.
So today we're going to talk a little bit about Cemiplimab and Fianlimab. So I guess the data have probably been presented a few times now, but we now have a publication as well, which is in the JCO. I think it was sort of June this year. I'm just bringing it up, which is probably the main thing that we're going to talk about. But I haven't really thought of any icebreaker questions for you, I must admit. Maybe I should have done that. Are you all out on, providing emergency assistance, in public or not? Was there more you wanted to say about that? You told the first story.
Oh, come on. Let's not kill people with our medical stories. This is... I have a whole book in me. I thought years ago I have a book in me. There's so many anecdotes, goofy things that have happened. Emergency. Yeah, there's so much here.
Okay, so when are you planning to use that snowboard that you took out of your car this morning? Let's hear about
that. So I got my rental for this season. Let's see. I need to go get a proper helmet. I've got some goggles, but I need to go get a proper helmet. And then I've got a season pass to do 2 different mountain companies. So I've got the Epic and Icon Pass for those who understand what that means. We've got snow at the tippy top of the mountains a couple of weeks ago, but they look still now melted and dry. We hit a record high here in Denver on Monday, September 30th, last day of September, 93 degrees Fahrenheit, record high. So that's about 32 centigrade or so. Does that sound right?
Sounds about right.
We do this.
Yeah.
Yeah. And then today we're going to have a record.
It'll be
No. Who cares? It's October 2nd. We're going to have a record high today. It's going to be in the 90s. We're going to break over a 100-year record. Yesterday was real nice, 80s. We're going to have fall in a few days, but we won't really hit fall until next week. So all to say, the snowboard will be lucky if it gets used in October. And there's only about 12 weekends left in this year, of which I have very few that I'm going to be even around. So I don't know. Stay tuned, though. We might
Okay,
record one of these from a mountaintop.
yeah. So I'm definitely going to ask you about that in the future if I remember. Okay, so I'll let you maybe introduce this paper, but while you're doing that, I could just ask you a question about verb again. So the very first word of the abstract is co-blockade. Now, is that definitely a verb, do you think, or not? I presume it must be, otherwise they wouldn't have allowed it.
It's a good question. There's no hyphen. You could, if your vision was failing you, you could almost say coblocade. You could almost get some of these letters jumbled. But we've heard you use some words that are dubious if they're in the English language. So I think it's okay. Cross-fitting.
Myocarditis. Yeah, that's not a verb. Have I said that?
Yeah, like
No.
we need to take you cross-fitting, or I cross-fitted this week. I feel like you've used it as a verb.
No, I don't think I said that. But anyway, okay, I'm not sure about co-blockade or, and
Okay.
Combined blockade,
Okay, ears
maybe.
up. Ears up.
Sorry.
Omid Hamid, first author, that there's already some controversy over your
In the first words.
the first word of the paper here. So phase 1 study of Fianlimab, a human lymphocyte activation gene 3, LAG3 monoclonal antibody in combination with Cemiplimab in advanced melanoma. Omid Hamid, first author, Carl Lewis, second author, and senior author is Giuseppe Gullo. I hope I'm saying that right. And like you said, this is in JCO, though we've seen some of this data over the course of the last couple of years. We saw it at ESMO 2022 potentially, and maybe the next year, and then we saw it at ASCO in 23. And I think you did a nice discussion on some of these LAG3 therapies. So, this is the phase 1 trial. So this is to say there's multiple cohorts typically in a phase 1, maybe different dose levels. Maybe it's patients who have seen prior therapy, who are naive to prior therapy. Have they gotten adjuvant or neoadjuvant? Is that its own prior exposure? And so you'll see in their table 1 that they have multiple different cohorts here of reasonable sizes. And, ultimately they're just sort of describing, I don't know that they were testing different doses here, and we can always check that later, but they basically are describing the efficacy. So it's just a phase 1, but it's 1B because it's in melanoma only. They do talk about LDH, greater than upper limit of normal. Of course, you and I have sort of said maybe 2x upper limit of normal is another way to really frame this. So would have liked to have seen that. But, impressively, they have a pretty good objective response rate here. Am I still in table 1? Is it just a big table 1? No, I'm now in table 2. So the objective response rate is topping 50% in all these cohorts. Systemic naive, prior therapy, prior exposure to adjuvant or neoadjuvant therapy. It is mostly PRs. They're not having as high a rate of, say, CRs as we see with CTLA-4 PD-1, but this combination is topping 50%. And I only say that to say that's relevant for the obvious comparison is there's another PD-1 LAG3 on the market and studied and approved. That's Nivo-Rela, and we didn't see a combined objective response rate above 50%. So here we are. So maybe that takes me to a question to you, James. Do we think all LAG3s are created equal? Is this a Pembro, Nivo, Coke, Pepsi situation? Or does this phase 1 data make you think there could be some difference? I am recalling something that you said Martin taught you about hang on when you see a signal in an early trial.
Yeah, all good points. I think to cut straight to the chase, do we think there's any major differences between anti-PD-1s? No, and we've actually got lots of trials which I think support that, but no cross-trial comparisons. What do we know about anti-CTLA-4? Well, to be honest, IPI's really been Tremi was developed a little bit in melanoma, I think, in the early days, but it's difficult to compare with IPI. Dose and schedule. And then LAG3, I don't think we know. It's as simple as that. So I don't think we should assume anything about this. We've got data for relatlimab. There's an approval for Nivo-Rela as well. So I think it's entirely possible that there could be a difference between anti-LAG3s, but it requires testing. And, the old school rule of oncology is always to, be cautious about efficacy in highly selected patients in early phase trials. I mean, the thing that's sort of those are impressive response rates, that goes without saying, and they've got decent numbers of patients. This isn't a tiny number of patients. I think the thing that jumped out, that was ASCO last year, wasn't it, 23? Was the activity in the kind of anti-PD-1 experienced refractory, whatever the word is, cohort, which looked very encouraging indeed, albeit with a small number of patients. So, maybe that's the time to go back to you and see what you think.
Okay, right. So objective response rate in all these cohorts looks good, high 50s. But you have some thoughts about some of the maybe conclusions the authors made about specific cohorts of interest?
Yeah, I mean, I think I agree about the relatively limited efficacy in the patients with metastatic disease who failed anti-PD-1. Anti-PD-1 refractory, the response rate there is kind of 10-15%, something like that, which is, I think, consistent with what we know for relatlimab, for example, in Checkmate 020. So I think that's consistent. And I guess my kind of overall comment about the paper is that if you look at that and compare it with the efficacy in the people who'd failed adjuvant treatment, and then this is quite a small group where you're really seeing a high response rate. And so one of the conclusions is, or potential conclusions, let's say that maybe LAG3 isn't as relevant in this situation to resistance to anti-PD-1. In other words, in the metastatic setting, which, that's a reasonable conclusion. Checkmate 020 data, I think, is fairly clear on that. But I think the other thing, and maybe for me this is the most important thing, is the response rate, the efficacy in the post-adjuvant group. Now, this is a small group if you really drill down into it. Excuse me, I think there are 18 patients, of whom 5 or 6 have had BRAF-targeted adjuvant therapy. So if you take those 5 or 6 out, as it were, then you've got 13 patients, I think it is, who had adjuvant anti-PD-1 therapy. Some of this is in the supplement.
Okay.
So then, what does that group look like in terms of inclusion criteria? I mean, how did they select these post-adjuvant patients? And again, I looked through the supplementary in the paper pretty carefully, and all it really says is you needed to be at least 6 months from your adjuvant therapy. And I think I said this when I discussed it at ASCO last year as well, and this isn't criticism, but this is a broad group of patients, okay, is what I'm saying. We don't really know exactly what the criteria were for these patients. And let's imagine someone who had adjuvant treatment, let's say a couple of years ago or something like that, and then they start progressing. We know that there's going to be some level of intrinsic sensitivity to anti-PD-1 in that group of patients. It's not a strictly defined refractory population. So that's one obvious difference for me anyway between the metastatic setting and, let's say, the post-adjuvant setting. And it would be great if this level of efficacy in the post-adjuvant setting that we've seen in this paper, comes out in the wash with larger numbers of patients. But I think that's the crux of this for me. This is promising, but what's it really going to look like in larger randomized trials? And coming back to the overarching point, are all anti-LAG3s created equal? Because I think it might answer that question. Anyway, that was my kind of take on it.
Is it fair? Did you read this paper, maybe based on what you're saying now, did you read this paper with the lens that I did, which is these are essentially not PD-1 refractory patients. All the cohorts they choose here are anti-PD-1 naive, systemic therapy naive, no previous PD-1 for advanced melanoma. And then they have this cohort of 18, like you said, previous neo/adjuvant therapy, of which some were BRAF targeted therapy, so it wasn't having to be PD-1 based. And it wasn't that they had to be progressing on that therapy, it's just that they had seen it. So this is not really a PD-1 refractory paper. This is a paper about a novel LAG-3 PD-1 combination in mostly PD-1 inexperienced patients.
Yeah, that's how I see it. And this isn't criticism either.
No.
And I think, I think the one group that probably clearly is fairly refractory is the metastatic group, where you're seeing this response rate of 10 or 15%. There's no question there at all. Yeah, it is. We can put in, as you would say there. And yeah, so I think it's shown, let me just get the paper up. I think it's actually shown, though, in supplementary, it's referenced in the main text. But if you look at the cohorts,
that's dangerous. I think
table 2, for example, tells you all these cohorts that we've just talked about, who are mainly sensitive cohorts, like you said already. But I think it's cohort 17 or something like that. So anyway, you're right. The point is that's not actually shown here. It's in the supplement, and that's the cohort where you can be confident that it's a proper refractory cohort.
Yeah, I mean, dang, you caught me, because that clearly shows I do not read the supplement here, and that's one of our takeaways. Always table 1, figure 1, supplement. So I missed that, but so then so what they're really showing us, and the meat of their paper, is PD-1 inexperienced. Then they have this small cohort that tracks with Relativity 020. Relativity 020 was PD-1 experienced. It ends up in that ballpark range. And so great to see this paper. Not a criticism, you're right. We're excited to have this option. And now investigate, as this combination seems to do, investigate how does it do in PD-1 actual experienced that are refractory, or how does it do in a directly coming off neoadjuvant adjuvant, whether you're progressing on that therapy or within 6 months of it, et cetera. It'll be nice to see that. So maybe as we wrap up, a couple of things here. Does this need to go head to head against Nivo-Rela?
No, I don't think so necessarily. I mean, is that going to happen or not? Because we're going to get data from randomized trials in due course anyway.
They have a randomized trial doing this.
Yeah, and so
the question of the company is: are you bullish and you're powering for superiority, or are you powering for non-inferiority? One day we'll have a statistician chat about that.
Yeah, so that's one thing. I mean, I'd love it. Obviously, if there was an anti-LAG-3 that had greater potency over what we've got already. But I must say I feel a bit conservative about that, and let's wait and see. Yeah, I mean, I was just going to, let me just read out this bit about that other cohort by means of a sort of quick fact check kind of within the episode, which is to say, so this is in one of the results paragraphs. It's cohort 7. This is the people who've got advanced melanoma who'd received anti-PD-1, and it's table S2 in the supplement for the demographics and baseline characteristics. And so the overall response rate, objective response rate there was 13.3%. And in a way, I think that's kind of all you need to know, because as you say, it tracks exactly, I think, with Checkmate 020.
Yeah. And then I just had 2 other kind of small things. One question for you is, do you know, was this a co-formulation or was it sequential infusions?
Yeah, I need to check. I don't know off the top of my head.
Oh, that's okay. We'll do something where we
fixed dose. No, here we go. This is in procedures. Sequential fixed dose intravenous Fianlimab and Cemiplimab, 30-minute infusion once every 21 days.
Okay.
So that answers that thing.
So LAG-3 first, and then the other. Have we ever seen a phase 1 of this? Do we know, like, is this the optimal dose? Is this the MTD? Do we know why this dose was chosen?
So no, I definitely don't know the answer to that. I don't know if there's a published phase 1 of this or not, honestly.
Okay. I mean, no, it was just a question I had. And then I've heard Hussein Tabi explain And it may go to some of this about response in metastatic PD-1 experienced versus earlier line of therapy, frontline therapy, or even after adjuvant, neoadjuvant without necessarily progression on therapy. He's explained that LAG3 and LAG3 inhibition, there may be something to T-cell exhaustion and the timing of when you bring in your LAG3. And it biologically may be that LAG3 inhibition gets less and less effective in a later line of therapy. That is not as scientifically articulate as he says it, but he has a nice explanation that I probably just need to hear and see a few more times. But there may be some biological plausibility about why it makes sense earlier in therapy. We'll see. We'll see.
Yeah, I agree.
What else about this? Anything safety-wise? I don't know if we landed on safety with this
We
combination.
didn't really, but I don't think we're seeing anything different really from what we might have seen. I mean, they're kind of small numbers as well, obviously, in terms of safety, but I don't think it really looks that different from Nivo Rela. I'd probably want to see bigger numbers before I started getting confident about that, actually.
So adrenal insufficiency looks like 12%. Is that fair to say?
Let me just pull that
Anti-PD-1
out.
for advanced disease. And then in the 15 patients that are anti-PD-1 experienced, it's about 7%, 6.7%, one patient.
Yeah, exactly. These are small numbers, though.
Small numbers. They
Yeah.
do have 100 of the
Yeah.
naive. What about myocarditis? Always gets my attention, but I don't see it here.
Yeah,
Okay.
and so it's not in table 4, is it? And I'm not sure it's referred to anywhere either.
Okay.
No.
Infusion-related reaction. Wow, 12% infusion-related reaction. Might be higher than
Yeah. I mean, I guess that's interesting, isn't it? And and we talked about this before, but I mean, I think once drugs get approved and you can access them, actually, if you get higher rates of infusion reactions between drugs that are sort of relatively similar to each other, that's the kind of thing that makes you choose. One regimen or another in the real world.
Yeah, I mean, I remember your partner, Andrew Furness, had somebody who had repeated infusion reactions across the whole PD-1 spectrum. COVID-19, that's an adverse event. No, I don't think I would have put that in the table. Okay, well, let's wrap up. That's Fianlimab Cemiplimab. So nice to see this published. Congratulations to the authors on getting this done. Congratulations. Sounds like there's a lot of work being done with this combination in new areas. The comparison to Nivo Rela. I think they have a neoadjuvant happening. There may even be an adjuvant trial. So this is not the end of what we'll hear, I guess, about Cemiplimab Fianlimab.
No, and I'm actually looking forward to seeing some randomized data because I think it answers some important
questions. You have
access
to these agents in the UK, the companies doing trials in the UK?
Yeah, they are. So I think their program's global, actually. So I think their trials are recruiting pretty well as well. So I would imagine they'll be recruited, early next year at the latest.
Opening it at the Sutton practice, maybe. Nice.
Yeah.
Nice.
Well, it's very nice down there.
Okay. Well, thanks for the chat. Okay, I'm going to stop it.